welcome to the World Parkinson's Coalition virtual YOPD program. My name is Omotola Thomas, and I am delighted to be your moderator for the next hour. I'm excited to be joined by our presenter, Dr. Bart Post, and we are thrilled to have you here. Welcome, Dr. Post.
Thank you.
Just as a reminder, this virtual YOPD series is divided into 3 tracks. The first track is the individual track, which focuses on the experiences of people living with young onset Parkinson's. The second track is the in relation track, which highlights the importance of relationships and their broader impact. And the third track, the medical track, explores medical approaches to managing YOPD, which is today's focus. If you miss any session, don't worry. We're recording them and they'll be available to watch by next Monday. We hope you've enjoyed the previous 6 sessions over the last 2 days and have found them informative and engaging. Today's session is focused on a very important topic: medical challenges specific to YOPD. The medical issues related to YOPD are vast, and while we cannot cover everything in one session, we'll dive into the challenges faced by professionals, patients, and caregivers during their interactions in the outpatient clinics. Key topics will include medication, dyskinesia, and dystonia. Time permitting, we'll delve into work-related issues and women's health. Dr. Post will also share insight into how his team have developed a specialized YOPD clinic inspired by a mind map created by someone living with Parkinson's. Before we dive in, let me quickly tell you how to engage during this session. On the right hand of your screen, you'll see a box with 3 tabs. The first is a questions tab. You can submit your questions here at any time, and would love for you to please ask as many questions as you have. The second tab is the resources tab, where you can download or view any materials mentioned during this session. And the third tab we have is a polls tab. We do have a couple polls in this session, but not all sessions do. We would absolutely love for you to participate in the polls and engage with us during this session. Finally, platform Cannabis Pharmacists in America. This program would not be possible without them. Now, let me briefly introduce myself and our presenter. My name is Omotola Thomas. I have been living with young onset Parkinson's disease for over 8 years, and I was diagnosed at the age of 35. I'm also the founder and the chair of trustees at Parkinson's Africa, an organization that was established to support and empower Africans living with Parkinson's disease. If you'd like to learn more, you can visit parkinsonsafrica.org. Our presenter, Dr. Bart Post, is a movement disorder neurologist with extensive experience in Parkinson's disease. He earned his medical degree in 1999 from the University of Maastricht and completed his neurology residency in 2008 at the Academic Medical Center in Amsterdam. His research on Parkinson's prognosis earned him a PhD in 2009, and he also became a certified clinical epidemiologist that same year. Since 2010, Dr. Post has worked at the Parkinson Center at Radboud UMC in the eastern part of the Netherlands, where he has led masterclasses on movement disorders and worked to improve care for people with Parkinson's. In 2018, he spent time with Victor Fong's team in Sydney, Australia, further expanding his expertise. At Radboud UMC, he co-directs the Parkinson's Foundation Center of Excellence, oversees residency programs, and leads specialized clinical and research groups focusing on YOPD. Dr. Post, it's a pleasure to have you. The floor is yours.
Well, thank you, Omotola, for this kind introduction, and thank the YWPC for having me to talk about this topic that really is in my heart. So I'm going to talk about the medical challenges, and as Omotola already said, there's so much to be said about it, but we only have like 45 to 60 minutes. So we had to choose. And again, if you have questions, just ask them and we try to address them within the hour. The first thing I'd like to know is how the audience looks like today. So that's why the first poll is out now. And while I go on in my slides, I come back to that a little bit later, but please let me know who is in the audience. These are the learning objectives for today: understanding why we have age cutoffs for defining Parkinson's disease at a young age. And then we dive deeper into the phenotype and the treatment. And the second part will be how to organize personalized care for people with YOPD and their caregivers. And I will share some experience from the Netherlands. There are two parts that I want to address, the juvenile Parkinsonism and then YOPD. And this is an important article talking about the age cutoff and the reason behind it. So I'm not going to use the article and spell it out for you, but you can find it in the extra materials and you can read it. But due to definition, 20 years and younger is juvenile, and between 21 and 50 it's YOPD, and the whole group I call early onset Parkinson's disease. And if you look at the prevalence of YOPD, it's around 3 to 5% in most studies of all people living with Parkinson's disease. In some parts of the world, for instance, Japan, it can be even higher, and that's due to specific genetic causes. Before we go on to the next slide, can I already see who is my audience at the moment? Oh, I have to look at a lot of people living with Parkinson's disease, I think. So A is the most, and 3 is, I have to look, it's the professionals. They're on 3, I think. Huh? Yeah. Okay, so most are patients and then we have some professionals. So, well, welcome and please ask your questions. So we were at the epidemiology and then how big is the group? So 5 to 10%. But for me, that's, it doesn't say all. So I try to bring it back to the Netherlands. How many people do we have? In the Netherlands, the juvenile Parkinsonism is really rare. I've seen several between 10 or 20, but it's rare. YOPD in the Netherlands, well, it's around 70,000 people with Parkinson's disease are living in the Netherlands. And if we have the 5 to 10% who are younger than 50 years, then it will be 3,500 to 7,000 people with YOPD. So still quite rare, but relevant group because they are in the middle of their life with families and with ongoing careers. So that's why we made work of it in our center. First, a really short introduction to juvenile Parkinsonism, because I think you should know something about it to really get what it is to have early onset Parkinson's disease. When you look at juvenile Parkinsonism, there are really a lot of articles about it. We wrote an article in Dutch, but there are also there is this review I wrote together with the group of Victor Fung when I was in Sydney. And well, all these reviews, they focus on secondary causes of Parkinsonism. So due to medication, due to a brain tumor, due to an infection, so really rare causes, but acquired. And then the second step is almost ever slides like this. A lot of genetic rare factors leading to juvenile Parkinson's. So this is really something for the academic neurologist who can well, make a diagnosis. So this is all rare courses. Don't learn them by heart. Just get the flow and get the people to the right person in your country. I think that's most important. There are 4 causes you really need to consider. 2, because they're treatable, dopa-responsive dystonia and Wilson's disease. 1, genetic cause, Parkin mutations. We also see them in YOPD. And then genetic cause, especially Huntington's disease. Huntington's disease is normal with chorea, but in a young age, you see them as a Parkinson's disease patient. So always think about those 4 because they really have impact on the way you have to treat them. I'm going to show you a little video. And this patient, she was 14 when she came to my outpatient clinic. And here you see some dystonia in the hands. And you see that she has bradykinesia. So she starts slowly, but after repetitive movements, you see it going down. You see that it's symmetric. So unlike Parkinson's disease, because Parkinson's disease is almost ever asymmetric, also in YOPD. You see the dystonia in the face with the eyebrows going up. And here you see the bradykinesia again. So maybe the right side is a little bit more affected than the left side. And here in the legs, you see the same, really slow movements. And then with walking, you see the dystonia on the core of the body. So this is a young girl with Parkinsonism and dystonia, and later on she was found out to have Huntington's disease without a family history. So rare, but you should be aware of this kind of causes. Then we go on to YOPD. Why do we talk about YOPD? What is it different from later onset Parkinson's disease? And what about the research that's been done about it? Well, there are only small cohorts, case series. A lot of it is retrospective. There are a lot of expert opinion reviews, but there are no good prospective cohorts. At the moment, we are working on a prospective cohort in the Netherlands for young onset Parkinson's disease to get harder evidence. But there are something to say about it. What's really important to keep in mind is that when you talk about YOPD, you need to know where people are in the course of their disease. So do you have it? Is the diagnosis already being made? Is it in the early treatment phase? Is it in the later treatment phase? Or are you already like 30 years in your disease? You're still someone who got this diagnosis at a young age, but you can live with it for a long time. So you have to take that into account when you read your literature. Well, this is a really excellent paper about YOPD. It's around 170 patients. And as you can see here, I hope, they have a disease duration at the time of being asked to participate in the study of around 13 years, as opposed to the later onset group who were like 8 to 6 years into their disease. And so that's important to keep in mind, but still, you see here the age of onset was 38 in this group and 51 in this group. So a really nice big cohort. And what does it show? It shows us that tremor as a presenting symptom is more common in older age onset. So here it's 65, 55 to 64, it's around 60%, but in the youngest group, it's only 30%. So that learns us that typical YOPD patients are more of the agenetic rigid subtype. So there's not always tremor. Yeah? So that's important to keep in mind when you are in your outpatient clinic and trying to diagnose a patient, that tremor is not always there. And next to this agenetic rigid subtype, you see a lot of dystonia. So the presence of dystonia in this group was around 60%, but at onset, it was already 20%, as opposed to the later onset group, where it was at onset only around 5%. And you see here, the older the age, the lower the presence of dystonia. So we don't know why this is. There's no pathophysiological reason for that, but we see it in outpatient clinic. So YOPD is more often akinetic rigid combined with dystonia. The dystonia is mostly in the off phase. It can also be in the on phase. We come back to that later. And there is one really special type of dystonia, and that's exercise-induced dystonia. We see this in around 15 to 20% of all YOPD patients. And I want to highlight it because, well, it's not easy to treat, and it's a lot of time is missed as a diagnosis. This is patients who tell you that during exercise, for instance, running or rowing, or in the Netherlands, biking, of course, they get these problems mostly in the foot with inversion of the foot, so plantar flexion of the foot, and they have to stop their exercise. And if you recognize it and treat it well, people can go on back to doing the exercise. And we all know how important exercise is for people with Parkinson's disease. I have a video where you can see this exercise-induced dystonia. It's really subtle, so I talk you through it. This is a patient who we asked to walk on this treadmill, and you have to look at the right foot. After like 10 to 15 minutes of walking, you see the clawing of the right of the foot, and especially of the toes. And well, this patient we treated with botulinum toxin, and he could again do his exercise. And before the botulinum toxin, he had to stop his exercise around after 10 to 15 minutes. So if you hear this, try to put patients in the position where they get this problem, and look at the feet or look at the hand, and then go from there to think about treatment. So really important, and very often in YOPD. If you go a little bit deeper into the phenotype, then, well, what makes it different? What's really different between late onset and young onset PD is the progression of the disease. On the right side here, you see a figure of a nice review, and here you see that the levodopa response in young onset patient is almost ever really excellent, and there's a slower progression than later onset. So that's what we call the paradox of getting young onset Parkinson's disease. You get it at an earlier age, and your progression is slower. We don't know why this is, but you see it in all the cohort studies. Then something else. There's a lot of debate on whether quality of life in general is better for YOPD as opposed to later onset PD, or lower. In this big study with 10,000 patients with the Parkinson Foundation Quality Improvement Initiative, we found that quality of life is in this group better, and that there's a less caregiver strain, but still there are a lot of unmet needs of people living with Parkinson's disease, and we come back to that later. So this discussion is not closed for the moment, and there's quite some literature out there. And so we come back to that later when we talk about how to improve care for YOPD. Okay, I want to have a short reset because we talked about the phenotype, and I want to go on to treatment. And I have my second poll, and that's what kind of medication was started as your first treatment? And so you have to think back, when was your medication started, and what was your first treatment? Was it the dopamine agonist? Was it levodopa? Was it the MAO-B inhibitor, or was it something else? And while I wait for your answers, I will go on to the next slide. Around 5 years ago, I was involved in this study. Rob de Bie from Amsterdam, he initiated it. And we looked at whether levodopa could slow the progression of Parkinson's disease. That was the real question. And we did that in a delayed start design. So here you see it. This is the UPDRS score. This is the group where people at the beginning got levodopa and then were followed up for 80 weeks. This group was giving placebo and then at 40 weeks also got levodopa and was followed up until 80 weeks. What we wanted to know is whether the early start group would be better off at 80 weeks. And if that was the case, then early levodopa would slow the progression of Parkinson's disease. Well, here you can see it doesn't do that. So it doesn't make any difference whether you start early or whether you start later. But then, what about dyskinesia? It was the same in both groups, 10 and 12%. And then we found something really nice because this early start group, these patients could only participate in the study if their quality of life was really good and they didn't need any levodopa. Well, we made we had to say as a treating physician, well, this patient can go without levodopa, as we think we were thinking that this patient could live without levodopa for about 1 year. And still, so the quality of life was good. And still, if you start levodopa, the quality of life is better. So in people with good quality of life, you can even improve quality of life by starting levodopa. And that's one of the main reasons that we say at the moment that you should start early with the treatment of levodopa. This is for the whole group. In this study, we only had 14% YOPD patients. So there's still debate whether we can extrapolate this conclusion to the YOPD group. But still, it's important that you know this study. Another excellent study we use in the discussion what to start is the PD-MET study. PD-MET is a trial where people were randomized to get levodopa or levodopa sparing therapies like dopamine agonist or MAO-B inhibitors. On the left side, you see the levodopa in red and the levodopa sparing strategies in blue. And here you see the mobility score on the quality of life on the PDQ-39. And you see there's no difference. So it doesn't matter whether you have levodopa or levodopa sparing strategies. And here you see the summary of the PDQ-39. So from this graphs, you can think, well, it's okay, whatever you start. But then you come to, for how long was the first started treatment still used during the 7 years follow-up? And here, on the lowest part, you see the red line, it's levodopa only. And you see that levodopa only was only in like 7%, it was stopped. And you see the dopamine agonist was around 50% after 7 years was stopped. And with the MAO-B inhibitor, it was around 70%. So when you start with levodopa, you can like treat it for 5 to 7 years with only levodopa. If you start with an agonist or a MAO-B or inhibitor, the chances are really high that you have to switch later on to a more powerful treatment, most often levodopa. So that's why we say just start with levodopa. It's the cheapest, it's the best treatment. And even in YOPD, it really works well. In this study, it was 12% of YOPD patients. Still, again, you can discuss whether you can extrapolate this data to the YOPD group, of course. What's really important is, because what's keeping YOPD patients from levodopa, because there's a lot of levodopa phobia, especially in YOPD patients, that's dyskinesias. In this study, you see it doesn't matter whether you start levodopa or whether you start levodopa sparing therapy. In the end, after 7 years, around 30% of all patients have dyskinesias. And of course, this is due to adding levodopa along the way, because you can't go on having this levodopa sparing therapies. So in the end, it doesn't matter whether you start early or whether you start later. But why then this levodopa phobia? And that's because of the dyskinesias. We are really afraid of that. And why are we afraid of that, especially in YOPD? It's that for people who are between the 40s and the 60s, around 50% of people will get dyskinesia after 5 years. But when you are before 40, almost everyone gets dyskinesias within 5 years for this really young age group. And if you get these dyskinesias, then a lot of people think that it's not easy to be treated with the dyskinesias, but that's not true. Only 12% of all patients with the dyskinesias can't be treated with simple adjustments of medication. So lowering of levodopa, adding something else like amantadine, or adding a dopamine agonist, and you can get rid of the dyskinesias. But the dyskinesias that we're really afraid of are these biphasic dyskinesias, and I have an example here. This is a patient who is here in his off phase, so without medication. It's from our center. You see the slowness of movement, and then 15 minutes after starting levodopa, he gets this really weird dyskinesia, especially of the leg, and you get this like dancing walk. And this is a kind of dyskinesia that's really hard to be treated, and almost ever you have to almost get rid of your levodopa and treat this patient with deep brain stimulation. And if you see this kind of dyskinesia, well, I can understand that you have a little bit of fear of levodopa. But the point I wanted to make is this kind of dyskinesia is really rare, and we shouldn't be afraid of levodopa. It's a really great medicine, and it's the best we have for Parkinson's disease. And of course, we should combine the strategies of dopamine agonist, levodopa, MAO-B inhibitor, and later on, a lot of young onset patients get these advanced treatments. So in the Netherlands, what do we do? And I think it's normal around the world that we do this shared decision-making strategy where we discuss all the evidence I've shown you together with the patients and his spouse, and discuss whether to start levodopa and dopamine agonist and a MAO-B inhibitor. But I think that the time of levodopa phobia is behind us, and that we should really also in YOPD treat patients with levodopa early in their disease, because it's really, well, changing quality of life, as I have shown you. Okay, so after therapy and after saying something about the phenotype, we go on to caring for people with YOPD and their caregivers, and especially what did we do in the Netherlands. And I want to start with this picture. This is a picture of me. I'm on the right in the green jacket, together with Xander van Ruijsen. He is on the left of the picture with the gray jacket. And Xander is a patient living with Parkinson's disease. He was 42 at the moment. And I was a young neurologist. It was 12 years ago. And in the Netherlands, we have this tradition of biking a lot. I hope you know it. And we were cycling together with patients. We do that once a year. It's called Bike for Parkinson's. And we were cycling in the south of the Netherlands. And we were talking about, well, what it is to live with Parkinson at a young age and what I can add as a doctor. And then Xander said to me, well, during your outpatient clinics, you're always talking about tremor, about rigidity, about bradykinesia, but well, that's okay for me. I don't have a lot of problems with that. But my main complaint is that I'm worried about work. I'm worried about my daughter. She has to go to study in 10 years, and can I pay that? And what about my wife? She's young. She's in the middle of her career, and well, can you help me with that? And I was never trained to think about things like that. And so Xander, he made this mind map due to the conversation we had on the bike. He came to my outpatient clinic 4 weeks later with this mind map he made together with his wife. And I'm going to explain you the mind map. In the middle was the integrated care for YOPD patients. And here, this leaf is about the motor problems. And I was only talking with patients about 12 years ago, not at the moment anymore. 12 years ago, I was only talking about the smallest leaf. I was talking about tremor, bradykinesia, rigidity, and I was adding medication. But I was also interested in his private life, but I wasn't thinking as a doctor about it. But he said, well, you should look into the social, financial part, the caregiver part, work, psychological differences, but also, can you think about how to change the way the organization is focused on young onsets? And with this mind map and the talk we had, we wrote a project together. We got around $300,000 and we started a project, and now that's history now because it's 10 years later. We still work together, and we have this movement in the Netherlands, and now we're sitting here talking about YOPD as an example. So we're really proud of that, and it was started with Xander. So great that we work together. And what we're really proud of is that his mind map is been translated to English, but even to Chinese. So around the world, his mind map is being used to change the way we organize care for YOPD. Is it only what we think should change? Oh no, there are a lot of papers. This is an excellent one about the psychosocial needs, and especially the unmet psychosocial needs. So also in the literature, it comes back what we were thinking in the Netherlands. You see it back in literature. This is a recent review. So this is a call to change the way we organize care for this special group. And well, knowing this, my question to you as a person with Parkinson's disease is, can you tell me what is your most important topic that needs to be addressed by your interdisciplinary team? So just give me words about what's your most important topic. And I think you can add more words, but try to make it simple, short words. And then we come back to that later as we make a word cloud of it and we talk about it. So what did we do in the Netherlands? In the Netherlands, we work according to this hub and spoke model. And I talk you through it. At home, there are the patients living with Parkinson's disease, and they have their personal care manager or their Parkinson's disease nurse. And they have the regional Parkinson's disease team, medical specialists, allied health professionals, rehab center, nursing home. everything. And then you have the hub. The hub is a central place, almost every academic medical center in the Netherlands. We are one of the hubs in Nijmegen for, well, thinking about changing care, and then we bring it to the patient. So the patients don't come us, we bring it to them. So that's really a different way of thinking we have. And that's why we started YEP, we call it. It's Young and Parkinson's. And within this movement, we work together with patients. This is our YEP crew. And here you see that we have several different people with different backgrounds in our team. This is Luzanne. Luzanne is a physiotherapist. Then we have Marit. Marit is our project manager. Then we have Gerben. Gerben is a patient with Parkinson's disease, and he is in our team. He's really working in the Radboud GMC for 1 day. And well, he is our marketing manager of the team, you can say. Then we have Wilanka, she's a PhD. Then we have Colin. Colin is the occupational health worker. Then we have Xander, already talked about. He's a patient living with Parkinson's disease. And well, together with me, we founded the YEP crew. This is Annelien. Annelien is a special woman. Maybe some of you know her. She is a patient living with Parkinson's disease, but she's also a gynecologist. And she is being appointed in our hospital as a crew member, but she's also working 1 day a week as a postdoc researcher together with Wilanka and myself on women issues in YOPD, and we come back to that later. And then we have Jet, and Jet, she has a partner with Parkinson's disease, so she is one of the caregivers. And with this team, we are talking about what should we change in care. We are talking to the group of YOPD patients in the Netherlands. We try to bring in their opinion. We discuss it. We try to change the way we work, and we all have an equal voice. So that's really important. So we make decisions with the whole team, and it's not that I, as a neurologist, will say, well, we go that direction. No, we just together we make the decisions, and everyone's voice is equally important. And in the end, we want to improve the quality of life of persons living with YOPD and their context. So it's not only about the patients, it's also about the children, also about the caregivers, really important. And we do this in co-creation, and that's the development and design and implementation of a service, equal collaboration with mutual respect between all parties involved. And then we want to equally involve people with Parkinson's, the informal and professional caregivers. And by doing this in co-creation, we think, and we also doing research on this topic, we think we can do the right thing and choose the right things to do. And in the end, it will lead to more efficient and better quality of care. But we're looking into that at the moment in a research way. Within Young and Parkinson, we do 3 things. We are about health innovation. I'm going to show you 4 examples in a few minutes. We organize meetings where people with YOPD can meet each other and they can feed our program. And we try to set the agenda. So we also we give YOPD a face in the Netherlands, and we try to talk about it as much as we can in all kinds of media. And last I think spring we were on national television talking about YOPD. So that was really setting the agenda in the Netherlands. What about health innovation? Well, there are several parts of it. First, there's knowledge. We try to get knowledge, we try to create knowledge, and we try to disseminate knowledge. And within 3 months, we have this Dutch platform for YOPD. It's going to be launched, and we hope to translate it to English later on with all recent knowledge about YOPD. Then we have 4 services. The first is about dystonia, because it's so often in YOPD we have a special service together with the rehabilitation medicine. Then we have the genetics, because as we know, the younger you get, the higher the chances that you have a genetic form. Then we have this special occupational rehab outpatient clinic. It's every Thursday morning. It's all about work and PD. And then we have the women and PD outpatient clinic together with the gynecology, and everything in co-creation. And at the moment we are expanding our cooperation worldwide. We work together with the Mayo Clinic in Rochester at the moment. And we started a collaboration with the Movement Disorder Society to work together on women and PD. I come back to that in a few slides. Well, here an example. On the left side, you see a slow motion video, so it really needs to be slow. And you see this patient has an exercise-induced dystonia. You see that the left leg of the patient and the right leg on the video is inverted during walking. And this patient really had a problem. So we sent them to the walking lab, and we try to find out which muscles then are involved and give them botulinum toxin. And here you see the results after deep brain stimulation and botulinum toxin. And you see a real difference, I hope, about how the food is used. And this patient could go on to doing exercise. And we think it's really important that people are put on in this walking lab, because then you can select the right muscle to inject, and so have the most optimal results. So that's one of our services. The second service is about work. Work is really important, especially because we know that the time to loss of employment for your YOPD patients is a median of 6 years. Around 82% are out of work in 10 years. So work and thinking together with patients about work and how to keep them in work and how to help them keeping up their work is really important. And there's not much research about it. This is a nice review you see here on the left of Rebecca Mullen. So I really would recommend that. And at the moment, we're doing new research in the Netherlands about how we can optimally help people to stay at work and try to participate in this really important part of their lives. I want to share this insight from the review because it can help you as of tomorrow. Because what's important in work is that there are internal factors and external factors. If you look at the internal factors, it's about the Parkinson's disease itself. It's about coming to terms with the Parkinson's disease diagnosis, really important. How do you cope with the disease? But also about what kind of symptoms do you have? What kind of work do you do? Do you have this exercise-induced dystonia? Do you have a tremor? And it depends on where you work. So how in control are you of your Parkinson's? And then there are the external factors, the line manager, the adoption of the law, workplace policy, available resources. And the combination of the control of your Parkinson's and the external factors, they're cross-linking. In the end, the cross-link, the interaction between these factors within and between will make you how you can achieve success. And well, this is a simple graph, but explaining it makes it a lot more difficult. And in clinical practice, it's really difficult to give general advice about a person who is working. So you should really make a deep dive into this patient's work, this individual Parkinson's disease, and combine it and give an personalized advice. And well, we're doing research now because we think it's important to get evidence out there that there should be more programs in the world that can be facilitated and well, paid by the government to keep people with YOPD at work. Then the fourth service we have, it's about women, YOPD. This is a really nice article about all the unmet needs of women living with Parkinson's disease. Again, together with one of our team members, Annaline, as a patient, but also a lot of other really important people in this field. And I want to focus on one thing. So I pick out one thing, and that's pregnancy. Why? Well, pregnancy is extremely rare. It's rare to have Parkinson's disease as a young woman, and especially in the childbearing age. And then becoming pregnant is even rarer. In the Netherlands, well, we have like 5 to 10 patients on our outpatient clinic that we have followed during a pregnancy. And there are a lot of questions. Is pregnancy making my PD worse? What kind of medication can I use during pregnancy? Should I deliver at home or in the hospital? What about lactation? So there are a lot of questions, and we don't know the answers because there is no evidence. There's only these reviews, there are some case reports, and at the moment, it looks like PD is worsening during pregnancy. We think that a lot of this thoughts about worsening of PD due to pregnancy is due to stopping the medication, because a lot of people are afraid of getting medication for the baby. So that's why Annaline, Wilanka, and I set up this international registry, the PrexPark. It's live since September of this year. It's at prexpark.com. And if people are living with Parkinson's disease at a young age and are pregnant, they can subscribe here to this study. And we send out some questionnaires, they fill it out, and we follow them during their course of the pregnancy, and also during delivery and in the lactation period, 3 months after the delivery. And by using this women-based, so the women go to the website and put ourselves in as a research topic. And by using this, we hope to get evidence on how to treat and to get guidelines for treating YOPD women who are pregnant. And we are really thankful that the Movements for Society has endorsed this registry and are helping us now to make this registry the worldwide registry for pregnancy in Parkinson's disease. So you will hear from this later on. But if you know someone who is pregnant and living with Parkinson's disease at a young age, you can redirect them to this registration. We tried to make a review where we summarized all what we did until 2020. I think we can now rewrite the review because the last 4 years we have added a lot. So maybe in the next 2 years we will make a new review about YOPD and how you can tailor the approach even further. This is our view of the future, that we have this center where you come in, just sit and work or drink your coffee and meet other people share your experiences, and then come to our outpatient clinic, come to my clinic, come to Bas Bloem's clinic, because we are seeing all the young onset patients. We talk about your individual care goals, and sometimes we just give a lecture for all the people who are in the waiting room, in this kind of waiting room, and talk to a group. So it can be really, well, it shouldn't be that awful to be in the hospital, but you should be as less as possible in the hospital, and you should live as much as possible. That's what we want to achieve by focusing on YOPD and care. I'm already at the end of my talk, and I want to end with a quote of Tom Isaacs, the late Tom Isaacs. And well, he said that this is a time of cautious hope instead of conservative paternalism. And I really like this quote because, well, what we need to give these YOPD patients is cautious hope, because we learned a lot about the disease. We are all looking for the cure, but it's still important to care. And we should go away from the old paternalist medical specialist and go to the medical specialist who's really listening to the patient and try to create a better quality of life. So I hope that I shed some light on different topics on YOPD and about the phenotype, about therapy, and about care delivery in YOPD. And I'm open for all kinds of questions, and I'm looking forward to discussion with Oma Tola and the others that are here.
Thank you very much, Dr. Post. That was, excuse me, that was a very insightful and informative session. As a person living with young onset Parkinson's, I was particularly interested in three things that you said. The three things really caught my attention. One of them was exercise-induced dystonia, starting early, levodopa and the paradox of YOPD. So I think I will start with, we have a few questions, and I just have to say we may go over by about 5 to 10 minutes, if that's okay, just letting the audience know that. So, speaking about dystonia, I have a question here for you. Can you further explain dystonia and how is it different from tremor? Does everyone get it?
Yeah. It's a very good question. Well, tremor is about rhythm. So that's things like this. And dystonia is about abnormal posturing. So dystonia is really abnormal posturing, tremor is rhythm. I think that's the main difference. And in Parkinson's disease, you see a lot of combinations of abnormal posturing and tremor, for instance. So it's often combined, but dystonia is about abnormal posture.
Thank you very much. Going back to what you had said about levodopa, I, experienced that. I refused to take levodopa for a long time because I was quite concerned. So knowing that many people have concerns about starting levodopa earlier due to fear of dyskinesia or other long-term effects, can you just quickly touch on what levodopa is and why it's such a common issue, and why people with young onset perhaps should not have levodopa?
Yeah. Well, it's a really important topic, Omatola. So thank you again for addressing it. I think levodopa is something that's been created 20 to 30 years ago, especially because then we were thinking that early start of levodopa and how much levodopa you got during your life was the reason of getting dyskinesia. But at the moment, we know that it's not about how much levodopa you've had during your life, but about the timing of the start of levodopa. As I said, we were talking before the talk about this is the disease progression. So here we are at the start, here are about 7 years. If you have your levodopa at the start, you will get dyskinesias around 8 years. If you start levodopa at 7 years of your disease progression, you also get dyskinesia at 8 years. So now we know you get dyskinesia due to levodopa, of course, because that's the cause, but with interaction of your disease progression. So it's the matrix of where you are in your disease together with your levodopa, and that's going to give you dyskinesia. And that are insights from the last 4 to 5 years. And if you know that, then you know that it's not reasonable or it's not rational to postpone levodopa. But if you see this really severe dyskinesia I showed you earlier on, then it's of course it's logical that you think I don't want this kind of dyskinesia, and then you fear levodopa. So I understand that there is fear for levodopa, but I wanted to show, and I want to stress again, that it's really important to use levodopa as low and slow as you can, but use it because it's really important for your quality of life.
Thank you. So if I understand, what you're saying is that delaying delaying the start of levodopa does not necessarily reduce your risks of getting dyskinesia.
Yes, you understand me correctly.
That's a really important point, because for people with young onset, we really are worried that because we got the disease so early, we're going to have to, take the levodopa for a longer period of time, and that is what will cause us to experience dyskinesia quicker. Thank you. I'll move on quickly to the next question. Somebody's asking, what is the rate of occurrence of REM behavior disorder in YOPD, and is it predictive of how YOPD is progressing?
Yeah, so REM sleep behavioral disorder. Well, I'm not sure. I don't know the figures by heart. I think it's just like in later onset Parkinson's disease. It's an important topic. We know that it's when you have REM sleep behavioral disorder in the prodromal phase, you almost never get Parkinson's disease. But if you have Parkinson's disease, it's around 10 to 20%. I heard from one of our experts who's with me in the room, in my working room. Sherwan Darwish, he is an expert on REM sleep behavioral disorder. And he says it's about 10 to 20% of all PD patients have REM sleep behavioral disorder. But I don't know the exact figures for YOPD. So interesting question. So maybe I will try to find it out and maybe react to it later on through the blog or through the WPC.
Thank you. And would you recommend for some people to get DBS early?
Yeah, that's an important topic also. Yeah, if people get wearing off or dyskinesia, we try to do DBS early. Yeah, so even people in their 30s, we give DBS. So, and what's important there is that with DBS, you can lower your medication tremendously and get a lot of you get away from the side effects like neuropsychiatric problems, hallucinations, problems like that. So yeah, we do that early in the disease course, even 4 to 5 years after diagnosis. Also in really young onset patients. So even in the early 30s, we use DBS.
Thank you, Dr. Post. I have another question here. It says I'm a 38-year-old woman, and I was diagnosed with YOPD at 36. I gave birth to my son at 37 while on Sinemet. No one told me that Sinemet would block prolactin. As a result, I had low milk supply and did not achieve my breastfeeding goal, which was extremely traumatic for me. I
Yeah.
wish there was more awareness and managing of expectations on part of PD healthcare providers. I don't know, it's just a statement. I don't know if you have any comments to add.
Well, it's a statement that goes to my heart because that's why I'm doing research to the topic, because it's really important to get more information about it. And well, we're also working on a guideline in the Netherlands, but we want to make an international guideline for women with the childbearing age and with pregnancy and lactation, and also with advices about treatments during pregnancy and lactation. It will be expert opinion, but in the next 5 to 10 years, we try to make it as evidence-based as possible. But really, really good statement. Yeah, and we hope that in the future, other people don't have this experience anymore.
Just a couple more quick questions. I don't know if you'll know the answer to this because it's specific to the US and you're not in the US, but I'll ask it anyway. It's somebody's asking, are there any efforts in the US to make care for YOPD patients more comprehensive? I'm a 38-year-old woman and I have YOPD and my neurologist only cares about my motor symptoms.
Yeah. Well, we are working together with Rodolfo Safica. He is a professor in neurology in the Mayo Clinic in Rochester. And we visited him 2 years ago to talk about our program, and he's also implementing the program in the Mayo Clinic, and he's also talking about it in the US. So I think this the first step has been made, and we're working together really closely. So yeah, I hope that things will change within the upcoming years. Yeah.
I would just add, to this question that I think this is what organizations and groups like the PD Avengers focus on. So, yeah, just to let whoever asked that question be aware. Another question is, and I think we'll run up in the next 3 to 5 minutes. I've been taking levodopa, carbidopa for 40 years and suffered dyskinesia for the last 30, but switched to Rytary and the dyskinesia reduced. Is that common?
Yeah, if you lower your levodopa, then dyskinesia will subside, or will even will get lesser at least. And then you should add something else, and that can be a dopamine agonist or a MAO-B inhibitor. But in the end, a lot of young YOPD patients will end up having things like DBS or a pump strategy, because you don't get there with only an agonist or a MAO-B inhibitor. In the end, you need some kind of levodopa treatment.
This is from me. Do you know roughly the amount of the percentage of YOPD versus the general Parkinson's population?
Yeah, it's somewhere between 5 to 10%. It's geographically different. So I think it's around 10%. Yeah. But if you that's the definition. So the definition is lower than 50 years at diagnosis. So then it's around 10%. But if you look, for example, at work, and if you see where PD is impacting work, then in the Netherlands you have to work until you're 65. Then it's around 30% of all patients with Parkinson's disease. They are still working. So our work program that we started for the young onset patients is also helping a lot of other PD patients. So in care, we don't have this strict cutoff of when you are 55 then you can also use our services that we built for our YOPD patients. So the cutoff is really for research, and in care we are looking at the individual patient and look what he's needing. Yeah, he or she is needing.
Thank you. And the very last question from me as well. Talking about work and family and having young onset Parkinson's disease. For me personally, I have experienced some challenging cognitive issues. There are times when it's very difficult for me to process and articulate my thoughts as fluently as I used to be able to do it. So are cognitive impairment something that you see with a lot of people with young onset? And do you have any coping mechanisms or suggestions or tips?
Yeah. Well, thank you for the question, Amatola. And I think you're really fluent at the moment. So really like working with you in this on this occasion. Well, cognitive problems are part of Parkinson's, but we know from the literature that it's the cognitive problems are less in young onsets than in older onsets, but still can be really impactful also in YOPD. And it is really individually. So it's you have to personalize your statements around cognitive problems in YOPD. So there's in general it's less, and but still people who can't work anymore, for example, a lot of people experience cognitive problems and stop working because of the cognitive problems. And a way of coping, well, a lot of problems are in executive functioning, so planning, thinking ahead. And well, there are tricks for that. So use an agenda, make it, discuss it at work, and have this quiet workspace, have this times of the day where you can't be disturbed and just go on with your work. So there are really simple tricks where that can help you focus and keep us productive if you as people without YOPD can be on that age. So there's a lot to be taught with occupational health therapists about this topic. Yeah.
Thank you. I think for me, I just need to learn to plan better.
Yeah, that's important. Yeah.
This has been a fascinating and very interesting session for me. I learned a lot. Thank you so much for your insight.
Matola, we have still one thing to do, and that's what's the word cloud?
Oh, yeah, actually, yes. Do we have that?
Yeah. It's there now. I can see it. And in the middle, the most important factor that needs to be discussed are still motor symptoms. That's interesting, huh? That we said it's the smallest leaf in our mind map, but here it's the most important thing. But then fatigue, anxiety, menstrual, the cyclic problems of the women, menstrual problems, hormones, it's really important. Working, sports, fatigue. So you see all the things that come back into our mind map. I want to say some last thing about hormones, and then we stop this session because we have these nice sessions coming up. For women's health, it's important to engage a gynecologist who really knows what Parkinson's disease is, and then can put in his expertise on pregnancy, menstrual cycle, but also the menopause. And if you treat the gynecology problems really well, you don't have to add any PD specific medications. So that's really our experience, and we're going to come back to that in good research to make statements about that. So thank you for having me.
Thank you again, Dr. Post, for an insightful and enlightening session. Thank you to all of you for joining us and for staying. We apologize, we went a little bit over time. We hope you found the information valuable. All the talks in this series have been recorded and will be available for viewing next week. We encourage you to share this information with your friends, your family, or support groups who might benefit from watching these talks at their convenience. A big thank you again, once again, to Mitsubishi Tanabe Pharma America for their generous support in making this program possible. Before we wrap up, I need to remind you to save the date for the 7th World Parkinson's Congress, which is taking place from May 24th to May 27, 2026 in Phoenix, Arizona, in the US. I am excited. I can't wait. The Congress only happens once every 3 years, and the next one promises to be truly exceptional. We hope to see you there. Thank you so much, everyone.